All right. So I guess I did this right. Okay, so welcome to Cardiovascular Anatomy lab. Sorry, lecture today. Not lab. So we'll be going over specific portions of your. Okay, I guess I have to do this. So here are your objectives. And today we'll be going over the structures, a bit of some intro to physiology. I'm not gonna go too in depth like Dr. Kaplan's class. Y'all can have fun with that. A little bit of cardiac cycle and electrical conduction systems. Okay, so notice things are in bold here. So 7 liters of blood per day. Isn't that crazy? So how many people drink like soda here? Those 2-liter bottles. So it's like what? 1, 3.5 liter, 2-liter bottles of Fanta, whatever, that you pump through your blood throughout the day. So, and there's 2 major expressways, okay, so to speak. So you got I-4 and I-75. Okay? Which mean 2 major circuits there. So you got your systemic circuit, which basically is shot out from your heart to the left side of your body down the entire systems. It feeds all the systems of oxygenated blood. Then it starts running out of payload. It starts unloading making all its deliveries, like a little prime truck, and then comes back up to the right side of the heart with no deliveries. It's an empty little truck, so it needs more oxygen. So that's what we go back to the pulmonary circuit. So think of the systemic circuit as the truck is fully stocked with, what's your favorite thing to order on Amazon? Clothes. Okay, awesome. Clothes. Okay, so systemic Amazon truck has a bunch of clothes. He's going to deliver it to everyone's little house, throughout the body, on the left side of town. And he's going to go on the right side of town when he's running out of stuff. And he makes it back to the warehouse of Amazon where he gets more clothes. Okay, so think of the pulmonary system there that we went over yesterday, is where all your clothes are being made and they get shot up. Okay, sounds good? All right, think of a little truck going through your whole left side and the right side, come back up to get more. So the clothes is oxygen, basically. It's dumping it off on all your tissues. And yeah, so that's how it works. So this is how it really works. So these little guys, you've got your arteries, your big arteries. So you got your big aorta, basically shoots everything out of your intersystemic system. Arterioles, capillaries are literally on your skin, venules and veins. So all these little guys are basically involved with, the smaller ones are literally involved with the whole oxygen disassociation. They start basically dumping oxygen off to tissues. And that's what those are for mainly, as you can see there in this little part here, how that little interweaving of looks like a honeycomb right there. That's basically what's going on there. That's your oxygen disassociation going on there. Removing waste and deoxygenated blood. So while it's basically like you're getting a new pair of jeans, but you're giving away your old ones that don't fit or are all tattered. So just think of it that way, okay? So you're giving away all your waste products. And basically, once that's done, the blood is deoxygenated. It's not going to be as bright red. So that's one thing you can tell when in trauma, when someone gets brought in by the paramedics and they're bleeding. If it's bright red, you've got an artery, you got to hurry and save this guy's life. If it's oozing out in blood, it's like black blood is more of a venous thing. So. Okay, that means there's not much oxygen. So the brighter blood is, the more hemoglobin, more oxygen carrying capacity it has. The darker it is, it's more of a venous drainage there. So these are very important. So you got your arteries, arterioles, capillaries. So main thing what it does, I mentioned. So from this slide you can use a picture to kind of travel through your finger if you'd like. Pulmonary circuit basically sends deoxygenated blood and returns oxygenated blood to the heart. So it sends basically deoxygenated blood to the lungs to unload carbon dioxide and receive oxygen. It's like a little bartering going on there. It's like, hey man, what you got for me? Well, I got some CO2. Okay, well, I got some oxygen. Here you go. Done. Then you go travel to the rest of the town, right? So that's how it goes, and then it returns back to the heart to back out into the systemic system. Okay, so you learn more details in your physiology class. I'm just trying to make it fun for you guys. All right, so right ventricle supplies the pulmonary circuit. Okay, left ventricle supplies the systemic circuit. So left ventricle is a lot much stronger, it's more powerful. Why is that? What's that? Yes, perfect. Yeah, it has to reach the entire rest of the body. Um, has anyone partaken the Hulk ride yet at Universal? Okay. You know that first part, you're sitting there waiting, you're like waiting, oh my god, oh my god, oh my god, and then you hear Hulk like scream really loud and it shoots you out. That's like a left ventricle. Okay. I don't know if it makes that sound, but yeah, it's waiting there, filling up with blood and blood and blood, and it reaches a certain pressure differential and just shoots you out into the systemic circulation. I think it follows the same route. There's that little upside down thing. But yeah, if y'all haven't, hey, who hasn't been to Universal yet? Here. Okay, cool. That's fun. No, it's all right. Yeah. I think though your student government, I think, can arrange something for discounted tickets. It's just an idea. If y'all want to have like a Nova Shark Night out there or something, you can go on Hulk and tell me about it. I can't go on those rides anymore, unfortunately. But yeah, so systemic system, left ventricle, Hulk shooting you out into the park. Okay. Okay. All right. So. Okay. All right. Systemic circulation. So. Inferior vena cava and superior vena cava. So inferior vena cava is basically receiving the blood from your lower extremities that is deoxygenated or oxygenated. Deoxygenated. So kind of like a vessel there. Everyone's had their fun on the Hulk ride. We're all like, oh my god, that was scary. Oh my god, oh my god. And so they're going back up to the beginning of the ride. They're going to decide they want to go back on it again if it's like a slow day. Usually it's not. The line is like 3 hours. But and superior vena cava, where's that pulling the blood from? Here? The brain, right? All the blood's being, yeah. So yeah, so everything's meeting there and going back into the heart, to the right atrium. And then the tricuspid valve will open up once there's a certain amount of pressure to allow them to open, and then they'll feed into the right ventricle, and that will go into the lungs to get oxygenated. Okay. So, um, so yeah, so face I just mentioned. So nodal pathway. This is just a brief intro to it. So right ventricle, got your semilunar valves. Okay, you know that. Difference between that and the left ventricle goes to pulmonary trunk and the lungs. And the lungs will have their pulmonary veins inside there. So remember yesterday we ripped the lungs apart and kind of faced them towards you, and we passed a little heart model around. So these veins and pulmonary artery and vessels are the ones that are going to feed into those lungs. They have an idea of what's going on there. And that's going to go into further capillaries and venules, arterioles to basically collect oxygen into the blood and then go towards the aorta to be shot out into the systemic circulation. Okay, so here are your major vessels. Okay, so if I were to ask you which vessels are the ones responsible for returning blood to the heart, what are you going to say? Perfect. Okay. One will return blood from the lower extremity. One will return blood from the upper or your brain head. Okay. All right. So there's always something going on there. Okay. And it never closes. Vessels transporting blood away from the heart. Okay. So these are ones that are going to be responsible for basically sending stuff out into the systemic circulation so oxygen can be delivered to all the tissues so we can work and function properly. So remember these three little red guys that we discussed briefly in last lecture or the first part, those little trunks that come off of the aorta, the aortic arch. So they're back again. They're like, haha, we're back. You better know us this time. Okay, so yeah, so understand where these are located and where they're going. Same idea. You can draw them or see what's going on, and then your descending aorta is going to basically go down towards your thoracic and abdominal aorta, and then feed into your inguinal regions and your lower extremity. So it's all one big. It's like plumbing. Okay, so If everything's nice and open, it flows nicely, but if there's a clog or like a cholesterol buildup or a clot, it's going to create issues, okay? So, all right, so pulmonary circulation. So this is what happens, but basically we've just been discussing. So that blood that's deoxygenated needs to go back to the lungs to get more supplies, right? So um, it goes from the inferior vena cava through the right atrium, through to the right ventricle, and then gets pumped into the pulmonary circuit where the lungs are, and that's where all the oxygen, the little guys reload the truck with clothes again, okay, basically. And oxygen blood returns to the left atrium via the left pulmonary veins, okay? So things are in bold for a reason. We'll go from there. So this is the same slide as before, but these are going to revolve around the pulmonary circuit, okay? So pulmonary trunk, that is what's going to basically split into your, and on those structures, your pulmonary arteries, uh, they're going to be the color blue, okay? All right? And the pulmonary veins are going to be the color red. Okay, so don't get that confused. And then vessels returning blood to the heart of your right and left pulmonary vein. So I would get familiar with literally make 2 columns or something, or you want to do what's bringing blood back to the heart, what vessels are responsible for that, where they go, what structures. I mean, it's kind of like physiology, but I just want you to know what structures are adjacent or what's next, what's going on in the process, and then what structures are responsible for taking blood out of the heart to the body, away from it, okay? And that will kind of make things more efficient for you to understand all this stuff, okay? Because I know it gets a little wiry sometimes. Especially when you start talking about physiology, when you have to understand how much pressure it takes to open up the leaflets and how much pressure it takes back for them to close. But yeah, so that. So size of a fist. So everyone put their fist like this. Now match it to your partner. See which who has a bigger heart. All right. So that's the average adult pulse, okay? All right. Awesome. So you can see, that's the average, 14 centimeters, 9 centimeters wide. So yeah. How many of y'all have big hearts out there? That's good. All right. So obviously the heart is hollow. It's basically, when you see one in a cadaver, it's literally hollow. Um, it's kind of like it feels like a latex like prop in horror movies. Like that's what it feels like. It's kind of like it's a little heavy, thick. But anyways, yeah, it's hollow. It basically it used to traverse blood through there and pump. It's a big pump basically. It pumps a lot throughout the day. It keeps going. It's the overworked muscle in your body. So understand that. The reason why I did that yesterday, I passed the heart around so you can understand where the location is in between the lungs. Okay, the mediastinum is right there. Okay, and that's what feeds into it, and we have a working habitational process going on there inside the mediastinum. So the lungs and the heart live in the same little apartment complex. So, yeah. So the heart will literally, like its little apex on its side will rest directly on the diaphragm. Okay, I think in the lung PowerPoint yesterday, we saw that little outlines and shapes of organs can fit right in there, the cardiac notch, and then on top of the diaphragm, there's one on there where the heart literally just sits on there, okay? So that's where it sits, and the posterior part is literally where the right atrium, the back part of the right atrium is literally pressed up against the vertebral column there, okay? And the anterior part is at the sternum. So if I were to ask you the actual range of where the heart is, you should know this, okay? You should know it sits on the diaphragm, posteriorly the vertebral column, anterior the sternum, and it sits inside the mediastinum, okay? So we have superior aspect of the heart, so the second rib inferior to it, okay? And around that area is like the major arteries and major trunks that we discussed in class. So, and if you're asked whether the heart extends downward to the left, so it's kind of like at an angle, the apex of the heart. Remember, you all learned it in PD class. Okay, where's that located? Is it here? Is it here? Is it here? Or is it here? Right, right, the apex. Okay, don't look at me like, what's he talking about? But yeah, so intercostal space, midclavicular line is where the apex is. So ICS MCL stands for inter. Yeah. Okay. So that's where it's located. So remember those pictures yesterday of the guy with the lines? I said know these. You should know those. And compare it to this. Okay. All right. So here's a diagram showing you the placement of the heart based on what I just said. Notice in this part here. Here's the diaphragm. So see a little pen moving or no? Okay. All right. So see it's resting right on the diaphragm like a little pill. Here's the apex right here. And then here's the entire mediastinum right there. So this is a good idea of where things are looking like, okay? All right, so where are these things located? All right, so atria is located on the right. The right atria is located anteriorly because of the way the heart is positioned, and the left atria is posteriorly located. So, okay, so kind of all right, during break, I need if I'll have one of you go to my office. I have a little heart model. I passed it around last year and it made sense to everybody. So it's this big old thing. It's like a little one. It's very fragile. If you break it, we have to have some words later. But, but yeah, it's been passed through my family for like 30 years. Joking, joking. I waited till after I passed it around last year to say that. Yeah, no, yeah, waited last, but everyone got really like upset, so I'm gonna just preempt it this year. But yeah, so ventricles, right ventricles can be anterior, slightly anterior, and posterior. So know the actual positioning of it. Okay, that's basically important. So you can look at your complete anatomy, the anatomage. Literally, it's not like resting there like you guys think like, oh, it's just there straight. It's literally like certain subtle angles that's in, and I want you guys to understand that. Okay, it's not just sitting there like whatever it wants. It's sitting on a diaphragm. It's positioned at a slight angle. What atria is anterior, what atria is posterior. That's what I'm looking for. Okay. And then we'll go from there. Mitral valve is involved with the left atrial and enters into the left ventricle. Tricuspid is right atria and right ventricle. So, in your aortic and pulmonic valves, so are specified for the actual valve there or the organ they're involved with. So, which one? Where's the mitral valve located? Okay, left atrial. Okay, and where's the tricuspid valve? Okay, cool. All right, so yeah, think of the mitral valve as like a little gate before you get onto the Hulk ride. So, atria is right anterior, left posterior. So we can see here in the heart where it's located specifically. The way the heart sits is how I want you guys to understand how things are located, okay? Uh, this is the same thing again. But yeah, so you can see I'm stressing something here, right? What would that mean? Yeah, no, y'all seen already. Y'all took one of my tests, right? Was I honest with what I was saying? Pay attention to my class, right? If you don't, you're gonna be like, oh man, this sucks. All right, so yeah, this is actually the model that I passed around yesterday, I think. It's a little shinier than the ones here, but yeah, just another example of what to look for. Okay, this is a different position of the heart and where everything is located in relation to its positioning. So here's the anatomage. The heart is hiding right there behind the ribs. Part of its sternum is protected, and it's in green in this picture. And here it is an anterior posterior image of the heart. So this is the posterior part right here, your atria. But yeah, like I said, you can play around with it, increase sizes, put colors in, take stuff away, add the vessels. So look how thick the myocardium is. So the heart muscle wall there. And then you got your endocardium, which is the endocardium on the outside part of the heart or the inside? Perfect. And the pericardium, where's that? Yes. Okay, so awesome. So we have same thing like yesterday in the lungs. You have a parietal pericardium, which is not attached to the heart part. The visceral pericardium is actually on the heart. And that's so basically you can get fluid and stuff trapped in there. It creates that like rubbing sound, and you get a pericardial effusion, pericardial friction rub is what it's called. So these are disorders that can happen from that. But it's basically an outer covering, like a Ziploc bag, so to speak. But it's like, if you all made like ice packs before, where you vacuum seal it, kind of way. That's kind of like the pericardium. It's literally like right up, very intimate. There's not much space there, but if you have like a sort of like a you get stabbed or something else is going on, it literally fills in that little space, increases, and puts a lot of pressure on the heart, and that's what can stop it from beating and could kill somebody. So, pericardial cavity, that's basically that space there is between the parietal and visceral. So if you were to, you see how it kind of folds. Think of it like, I don't know, you got your muscle here, and then you got this thing here. So this is your visceral pericardium, and then it folds out, and out here is your parietal out there. Okay, kind of like same thing as the lungs yesterday. All right, it's like just the outer saran wrap, so to speak, and allows everything to flow and beat nice and easy. If that wasn't there, the heart would be beating and rubbing up against all the other structure in the mediastinum, okay, and create lots of havoc and chaos. Okay, so that's what it's there for. The epicardium, where's that? Is that on the inside or on the outside? Perfect. All right. So yeah, so it's more intimate to basically comes back around, and outside of it, it's not really intimate to the heart. It's intimate to the parietal pericardium, myocardium, endocardium. Um, shoot, don't worry. Okay. So yeah, so it's basically what I just said. So what does the pericardium do? Without looking. All right, it allows for the heart to work basically friction free. Okay, so kind of like your ball bearings and your tires, you want those to be working, like be grinding noising, grinding, it has to be well lubricated, and we'll go from there. So it's a very, it's very, like I said, intimate to the heart. You can actually like, there's like a pericardial fusion. It's a very, you get like a 10 blade and very still hand. You do that and you open it. The cardiothoracic surgeons are responsible for that. I was just standing there going, oh my God, wow, this is crazy. I can't believe I'm seeing a human heart. That was my first time. You guys will feel that way too on rotation. It's crazy. You get home and, oh my God, I just saw it today. Anyways, but yeah, so so yeah, it's basically there for protection, anchors the heart in the place where it should be, and keeps it fixated so it beats without any type of interruptions or friction. And it also keeps it from overfilling. It's kind of like guide wires, so to speak, or it can keep going, and that's not good. You won't be able to get blood anywhere. It'll just sit there and create blood clots. So here are your heart walls. I would know these. So endocardium, myocardium, epicardium, pericardium, and it's surrounded by a protective layer of adipose tissue, which varies in size. So try to understand what each one of them does. Okay, so epicardium is going to prevent friction from that pericardium rubbing. So if you'll hear the term pericardial friction rub, have you all heard that before? Heard that term before? So that's when there's excess fluid or something going on in there that's preventing the heart from beating correctly. So it's going to beat and it's going to create friction and noise, and it'll already sound like sandpaper rubbing against each other when you're on your stethoscope. Okay, so you guys will learn that. I think they have heart sound or something in the book. Yeah, I think you can type in pericardial friction rubbing, you can actually hear what it sounds like. So. But yeah, so myocardium is your muscle. So your muscle, it pumps heart out, pumps blood out of your heart, so to speak. And endocardium is basically where the inner surface there. It's kind of not as strong as the myocardium, but kind of keeps everything in check as the basement membrane, so to speak. So here's some more diagrams here. This is another one that you can actually try and cover up and study from, okay, like you've been doing. You see these little guys over here? You see the red thing? So those are those three things I want you to know, okay? Guys that came back to haunt you from the last lecture. So. All right, so here's the back of the heart, the posterior part. This is kind of neglected, not too many of you know what it looks like. So, but yeah, I can see that this is the left atrium right here. All the pulmonary veins are located adjacent to that. And here's your pulmonary artery where it's going directly into. So this is a good one to kind of look at to compare it to what we saw yesterday with the lungs, the inside parts of the lungs, how it connects into there. But we also have your coronary sinus. Coronary sinus is basically this right here. It's a big vessel there that's going to feed blood to the actual heart myocardium. So it's the heart's blood supply. So when there's coronary artery vasospasm or coronary artery disease, the blood's not getting the heart is not getting the blood and oxygenation it needs. So what happens is it can become an ischemic situation, and that part of the heart can die if someone survives. Okay, the heart will be weaker, and they need put on inotropes and all sorts of other medications. So 4 hollow chambers you can see there. Two are upstairs and 2 are downstairs. Okay, think of it like a little apartment complex in your heart. Okay, you got 2 guys upstairs and 2 dudes downstairs. Okay, and so like in the hotel rooms, they have a little door that shares between the doors. So that's the atria, the mitral valve and the triclosan valve. Okay. All right. So yeah. So they're separated. The intra-articular septum is this thick wall here of muscle. Anytime you see septum, think of your nose. Or other thing is just dividing. It divides 2 hollow spaces basically. So your nose divides your nares. This divides your ventricles. But understand the whole process of where things are located, left versus right once again. And you can see that even on this diagram, the myocardium in the left ventricle is much thicker and stronger when compared to the right. Okay, why is that again? Yes, the systemic circulation. And what right am I referring to with that? Okay, good. All right, so kind of more physiology here. So blood enters the right atria from the following structures, and blood enters the left atrium from the pulmonary veins. Okay, so know where blood goes into, which artery, which vein. So yeah, so I put this in yellow from the anatomage for the left atria, and pulmonary veins are in red. Okay, that kind of gives you an idea what's going on. Is it in red? Okay. Okay, so all right, so slide over on 34. Okay, so blood clearing deoxygenated blood, as you know, leaves the right ventricle and it goes towards the lungs. You can see here I've labeled the pulmonary trunk in navy blue and navy blue, and then the rest in aqua. Okay. All right, so here's some more details on what happens in the right ventricle. As you know, the blood it receives blood. Right ventricle receives blood from the right atria. It sits there, it fills up to a certain point enough to close the tricuspid valves and open up the pulmonary valves to go into the lungs to get oxygen. Okay, you'll learn about that in physiology. I'm just kind of giving you an easy way to understand what's going on. Okay, and same thing in the left ventricle. It receives blood from the left atria. When it gets to a certain pressure point, it closes the mitral valves and opens up the aortic valves and shoots the blood out. Okay, it's all about pressure differentials inside there. So your heart valves, they're basically one way, as I mentioned. So once they get filled to a certain amount of pressure, they close, and then everybody ever I don't know, if you have your sliding glass door open and you open your front door, and one of your bedroom doors will slam shut. It's kind of like what's going on here with the valves. Is a certain amount of wind pressure occurs inside your house. It circulates, it gets trapped, and it's enough to shut a door. Or you leave a window open and the door slightly ajar, and you open your front door, and you're like, oh my God, what happened? think that your house is haunted or something. But it's kind of what happens here with the valves in your heart. They will shut quickly once a certain amount of pressure volume fills up, and then once enough pressure fills up in the atria, it'll push down and open up those atria and open up. It'll basically push down to the ventricle. Okay, so try that at home later. So, but yeah, so this is a more schematic here of what I just discussed in a more strict manner. Boring, not as fun as I would say, but all right, your tricuspid valves. There's three cusps. That's why it's called tricuspid. So, yeah, it's kind of what I mentioned. So, blood moving from your right atrium into your right ventricle doing diastole. What is diastole? What's going on there? Diastole. Am I contracting or am I filling? Diastole. Yeah, relaxing. Yeah, diastole or filling. So, diastole. It's filling. Is what you said?
Yeah, something like
Yeah, sorry.
that.
I'm sorry. Don't have any. I misunderstood. Let's take a break. um, yeah, so yeah, we're filling in diastole basically, and it's going to fill up to a certain point. So when that happens, the tricuspid valves will close to prevent backflow, and when that happens, it's going to create enough pressure to force your pulmonic valves to open into the heart. So basically like that experiment I just told you about, closing doors in your house and opening doors. So same thing occurs with the mitral valve here. So main job is to prevent black flow of blood into the left atrium. So once it fills up during diastole and it fills up to a certain amount, it shuts those closed. And then we have systolic contraction to push everything out into systemic circulation. Okay? You all following me on that or no? Okay. All right. So atrioventricular valves. So these are very strong. They have a specific fibrocardiac tendonae. Okay. So they're attached to little muscles here, papillary muscles, that basically sense pressure changes, and they will shut and open based on how much volume is inside each chamber. And if the pressure is right enough, it'll shut them. If it's low enough, it'll open them up again. So papillary muscles are attached to the ventricle walls. So when they close, they pull on the chordae tendineae. So that prevents the cusp from falling back into the atrium. So basically, it'll prevent everything from it'll shut down evenly like this instead of being like. You ever been to like a store and like the second floor? If you open the wrong door, like it'll look weird, like it won't close all the way. Y'all should try that. So on the second floor, if you like instead of going right to the anatomy lab, go around to like where the AE offices are, and like it'll say open this door, and open fine. But if you open the other door, it'll just screw it up. It'll leave it ajar slightly. So think of like that you're not closing correctly. If there's a problem with the chordae tendineae, so the chordae tendineae are going to open if it's done correctly. But if there's like one of the valves is like diseased and structured with like calcific deposition stuff, it won't close correctly. Okay. So, but yeah. So orange arrow, this is what they look like little web-like structures. Know where they attach to and what they do. Here's a superior view of them, so you can see a tricuspid valve has three. 1, 2, 3, and then your mitral valve is basically 2. All right, so we got your aortic valve and your pulmonic valve here as well from a superior aspect. So remember, move things around, know where things are located. So yeah, so let's take a 10-minute break right now. All right, so we got your heart valve. So we have some on the aorta and some on the pulmonary vessel there. So They're called semilunar valves because they kind of look like the luna, the moon. Let's not worry about that. So just know where they lie between. So lie between the left ventricle and the aorta. That's basically before, the Hulk ride shoots you out. Okay, little gate shoots you out. So basically that's what's going to be where the blood inside the left ventricle is going to fill up to a certain pressure, force those aortic semilunar valves to open, and it's going to contract and push the blood throughout the systemic circulation. Okay, pulmonary pulmonic semilunar valve is between the right ventricle and the pulmonary trunk. So this is not as a strong contraction. It's going to fill up and basically like pour the blood into your lung and all the capillaries to get more oxygen. Okay. Next, so here's what it look like superiorly. So this is another one you can study off of, so you can understand where everything's located. You can actually see the semilunar valves on a little heart model we're passing around. Okay.
I got one piece, not the other.
Oh, okay. That's fine. Well, it's
That
okay.
one's really hard to get.
I'm really sad. That's true. It's my fault. All that. See, that's what I get for joking around. But yeah, those more pictures here. So the anatomy module, it looks like this is an actual cadaver heart right here. That's what it looks like. So it's like a little bit of a latex horror item there. So just give you an idea of what things look like. So get familiar where the semilunar valves are, your mitral valve, your ventricle, your atrium. There's like two. It's like one of those. I know I used to live in one like that here in town. Like it had like two apartments on the top and two on the bottom. Like your atria, ventricles. Okay, atria and ventricles. Atrias were a lot smaller, cheaper apartments. Ventricles were fancy. Okay, so there we go. So yeah, this is basically what I was talking about, how pressure differentials cause certain valves to close and certain valves to open. And that's what you'll hear on your stethoscope. You'll hear that lub-dub sound. It's basically everything opening, closing, opening, closing. So, and the faster you run away from things or everything else, obviously the quicker and faster it closes the cardiac cycle. So here's what's going on during diastole. Your right atria and left atria are filled with blood. Okay, so where are they getting their blood from?
Maybe inferior and superior.
Yeah, you got it.
Oh.
Yeah, so the right atria is getting blood from where? Inferior vena cava and superior vena cava. Good. All right. Left atria is getting it from the lungs, the pulmonary vessels, which has filled with oxygen. Okay, so this is a cardiac cycle. I would understand this to help you understand what structures are where, what they're close to each other and stuff like that. So when the right ventricle, left ventricle relax, the AV valves open. So what's going to happen is like a trap door, right? That blood's going to fall into the right ventricles, and that's going to allow it to fill up. And then when that fills up, it shoots the blood out into the semilunar valves to open up into the circulation. Okay, so it's all about that. There are videos on the YouTube you can watch, I'm sure. So I'm just being funny, my age. On the internet, we now have the YouTube channel for the class. I look a little younger there. A little picture. With the chin strap beard. Well, it was cool back then. All right, so it's toward the ends of ventricular diastole. So when it starts to fill up to the point where that pressure differential is going to start things to close and open, the atria starts to contract, get that little bit of blood that's left in there out for what's needed, and then all of a sudden they'll snap shut and close. Okay. During systole, this is where blood in the ventricles has filled up to a certain point. It's kind of like a little alarm goes off, and it causes the ventricles to contract. When that happens, the atrioventricular valves will close to keep what from backing up into what? blood from back into the atria, correct? So you don't want to go back, you want to go forward. So it pushes blood out to the body if you're in the left ventricle, and if you're in the right ventricle, it pushes it where? Into the lungs, okay? But it's not going to be as strong. It's like the Dr. Seuss ride on the right ventricle. But the other side is the Hulk ride, which shoots you up. Y'all been on the Dr. Seuss ride? It's pretty. It's a good way to like rest your feet and get AC. It's like the line's always short, and you're like, okay. All right. So yeah. So at the end, after everything's contracted, um, they're done contracting. So then they've done their job. So now they're going to relax. So the semilunar valves, like in your aorta, are now going to close to prevent backflow. Yes, back into the ventricles. Okay. So then those will close, and then it all starts over again. Okay. So it's all about if you fill up your Stanley cup with water and you put the lid on it, it won't spill out. Okay. But if you're not doing it quick enough, it's gonna spill out. Okay. So same thing. All right. Everyone following along? Okay. All right, we're just doing it the fun way. You can learn the actual way in physiology class. All right. So. And yeah, so every time you're listening to your partner's chest on the stethoscope, one heartbeat is that entire thing we just described. Okay, it happens that quickly. Okay. All right, so cardiac cycle. So basically everything that's happening. So know the difference in these two. In systole, what's the heart doing? And in diastole, what's it doing? And during systole, what's going on with the blood? Is it being like filled or being shut out? Shut out. And diastole, what's happening? Is it filled? Okay, perfect. Okay. So yeah, so it makes this noise. So look, it's in red and underlined. The lub is also known as S1. Okay. Y'all have memorized S1 and all that stuff you have to repeat to us during your not yet? Okay. Well, you will. So S1 is when your AV valves close. So what is S1? Okay, what does AV stand for? And what are they also known as? S1. S1 sound, yeah, sorry. So the heart sound is S1 and it is AV valves closing, okay? The dub, the second part you hear in your partner's chest, is the semilunar valves closing, okay? So think what's going on. So if blood is filling into the atria, right atria from where? Yeah, inferior via cava superior, fill in there, and then the left atria from your lungs, pulmonary, and then that's filling up, and then it trapdoor, blood falls everywhere, and then those close. That's your S1 sound, your first heart sound. Okay, they snap shut to prevent backflow. Okay, and then when the when the semilunar valves, after they get shut out and the blood is in your systemic system and preventing it from backflow, it shuts down. It shuts the door basically. Like basically, it's like you've been kicked out of like a party or something. Get out and close the door, and you're trying to get back in. So that's kind of like the S2, all right? Can't. You gotta go around. Okay. All right. Does that make sense to you guys? Okay, so just visualize that happening, like blood passing through, and it's got enough momentum to go, but it's gonna try and get back into your heart, but those shuts the door right in front of you. You can't come back in here. You're done. Time's over. Go back line. Okay. All right. So during systole, what's going on here? What's closed? What's open? Okay, perfect. And what's open? Perfect. Okay. So if you get stuck, look at this diagram here. Okay. What's open? What's closed? I want you guys to understand that. Okay. When the semilunar valves are closed, what is open? V valve. Okay. Coronary arteries. Supposedly they're shaped like thorn crown of thorns. That's where the name comes from, coronary. Yes.
Sorry, can you go to the slide before? Just really quick.
I will try. Hold on, let me see. Get everything right for you. Okay, so right coronary artery is in red, left coronary artery is in blue. Next slide. Okay. All right. Right coronary artery supplies the following. So right coronary artery is basically in this region here. Right there. Your right coronary artery. Okay, so it's going to cover your right ventricle, a few percentage points of your left ventricle, SA node, AV node, and part of your posterior descending artery. Okay, so know what specific what specific regions are supplied by your right coronary artery. Okay, all right, let's kind of keep the little chatter down. Okay, being lenient, but we're being recorded here. Remember, we're on best behavior. We're going to be on the YouTube. All right, so so understand what part of the heart the right coronary artery supplies. All right, so posterior part. This is where the right coronary artery supplies the posterior part of the heart. You can follow it through in the diagram. Right here. How's the little heart going? Where's he at right now? Okay, cool. What do you think about it? Yeah.
Is this the size of our actual heart?
It could. No. Yeah. Well, put your fist next to it. You can see. If anyone has the size of that heart, it's pretty awesome. But yeah, it's a model. I just grabbed it off the internet. Uh-huh.
What's the opposite from systole and diastole?
Okay.
It has that systole is when, or it is that diastole is when the AV valve is closed. And then it has systole is when the
Yeah, that's what I meant. So,
okay.
yeah, it's closed while it's filling, and then when you're contracting, it opens up.
Okay.
Yeah, because it's going to shoot it out. Imagine like you're trying to break through something, or you're let's say you're in the bottom of like a basement, it's filling up with water, and you're finally getting enough buoyancy to grab the little latch to open the door. Yeah, so that's basically what. Yeah.
Just to break it on the test, because on the slide it says it's just saying
It's yeah, but it would be what's on the slide. But dynamically speaking, I'm just trying to give you the whole process. Yeah, yeah, you okay? Yeah. All right, so left coronary artery is going to basically, it's kind of like the roads here in Orlando. Okay, you got one big road and it turns into 2 or 3 other ones with some other names. Okay, it's not like the grid system in Miami where you can understand everything, right? Or New York City. So in Miami, the grid system, if my old address was 12304 Southwest 115th Terrace, so my house was on the corner of 123rd Avenue. So its first 3 digits in your address are the cross street of the avenue. So that's how things make sense. Here in Orlando, there's just names. It's just confusing to me. I don't know. How many are new to town here? I find it confusing, right? Like Severin Boulevard. Hey, oh yeah, I'm on Severin. Where? Such a long road. Are you by the airport or are you by wherever the hell the other side it goes to? Okay. So, but yeah, so left coronary artery turns into your left anterior descending and your left circumflex artery. Okay. So none of these are located as well. So where do the left anterior descending left circumflex artery emanate from? Left coronary artery. Okay. All right. All right, so LAD is going to surprise so there's more directional anatomical terminology, anterolateral aspect of the myocardium, the apex as well, and your septum. That's what's going to supply the blood there, and certain percentage points of the left ventricle. So basically make lists or whatever you do to understand what each of these vessels does and where they're located on the heart and what they supply. All right, so so this guy here, it's basically, they call it the term widowmaker because it basically turns people into widows because it's it won't supply enough of the blood supply it needs to the larger muscles. So if you're if your coronary artery is dependent on this one vessel, you're not going to have enough to sustain the heart muscle being oxygenated. And it's kind of doesn't have the same symptoms as a regular heart attack. You won't have like, oh, the left arm pain, the chest pain. It will just kind of be silent and people just die. So that's why it's called a widowmaker. This is just FYI. You know to know this, but I just thought I'd throw that in there to help you kind of understand why that term is used in the real world. Okay, so left circumflex artery is the posterolateral. What's posterolateral? What's that? Back into the side. Okay, perfect. Yeah, we got it. And 40 to 50% of the left ventricle. So know where it's located, know where it supplies. Okay. All right. And we'll go from there. So put a marker around that. Understand that what I'm saying is important to know. It's in bold. Ascending aorta and the surrounding structures as well. Okay. Same thing here as your anatomy picture. Now you can just put cardiovascular system and then get rid of everything else and just put the heart in there as well. Or you can keep the great vessels in there. We're going to have the coronary artery as well with the bottom slider button. That one has your blood vessels and your nerves, okay? All right, so coronary disease, I'm sure you guys have heard of this before. Plaques kind of build up from a poor diet filled with fatty foods, fast foods, and it creates an obstruction in the diameter of the lumen of your vessels. So it's like if like we're all trying to leave that doorway and we all put our backpacks there and there's only a little bit of walkway to get through. We're all gonna get slowed down. What happens with blood when you slow down? It creates a clot. Yeah. So blood has to be flowing freely at all times. If there's anything in the way of that, it'll become stagnant and become viscous and it'll create a clot. And that clot could travel somewhere else, like in your lungs, and kill you. Okay. So that is why we give people anticoagulants when they're bedridden, because they're not moving as much and stuff like that. Okay, so yeah, so way to solve this problem is to eat a healthier diet, exercise, and eventually they can do a roto-rooter. They'll go in there and clean it all out, or eventually they'll just have to give you a filter some point to catch a clot if it does happen. It's called a Greenfield filter. We'll learn about that in cardiology class. So there's another way to do a coronary artery bypass graft. So if your coronary artery is completely obstructed, they will harvest. This is a PA, just you're interested in this. So PAs can actually get extra training and certification on. All they do all day is harvest veins. That's all you do all day. Harvest veins all day and send them out to the cardiologist. Cardiothoracic pays really well, but it's kind of boring and mundane. But if that's what you're into, go ahead. But yeah, you get trained in that, and you harvest veins all day. And go over there and you put it with the surgeon, and then creates a bypass, like a little conduit around the blocked veins. That's how also we treat it as well. So yeah, so vein harvesting is usually the cardiothoracic PA's job. So okay, how many are interested in cardiology? Good. Yeah, you'll be on call a lot. It's okay. Pays well. All right, so veins are coronary arteries receives blood from the heart and returns to the right atrium. So that's what's going to drain the heart. So now we've just learned about what is sending blood to the heart. Now what drains it. Okay, so we've got these coronary veins, and this is where they're located. It's known as a coronary sinus back here in the posterior part of the heart. Okay, did y'all see that little laser panel moving around? Okay. All right, awesome. This, and here's what it looks like on the anatomy, your coronary sinus, which drains the blood from the heart. And think of sinus cavity, so it collects blood or drains, like in your nose and face. So think of it like that. So electrical conduction system. You'll have an entire course called EKG for this class. So it starts off with the sinoatrial node, which is located right over here. That's going to be the pacemaker of your heart, and it's going to basically send signals down to your atrioventricular node, which is going to stimulate the atria to contract and open up the valves. Then it'll travel through your intraventricular septum down to your Purkinje fibers and cause the ventricle to contract. Okay, so I would know where their location is. SA node is located where? Right atrium, right? So it's basically going to set the rhythm, all right? So if you have a diseased SA node, and we implant cardioversion devices or pacemakers in people's chests, and have a little device, the magnet, they turn it off and on. That's what we use for someone who has a diseased SA node. They need to have something. Their SA node starting is real low, like in the 40s, which is not good. It's basically going to make you sleepy all day. It's not going to be enough to push the blood along and create clots. So SA node should be around, your certain level of, when you take your pulse, so like that should be able enough to contract that atria to allow it to work properly. Okay, so it's a rhythm. It's basically the choreographer of rhythm. Okay, if you want to think of it that way. Um, so it receives its input from which cranial nerve? Don't look. Don't. Damn it. Disturbing. You looked. All right, so cranial nerve 10, vagus nerve. So it's going to send the impulse. The vagus nerve is going to, remember, it innervates a bunch of organs. It can sense the rest and digest system. It'll basically tell it, okay, here's your starting point for cardiac rhythmicity. Rhythmicity. Yes, that's the word. So then that gets the impulse there. It'll send an impulse to the AV node, which will then allow the atria to contract and work correctly. Okay, so basically without the electrical conducting system of the heart won't pump. Okay, so it's basically the heart won't work if it's not plugged in. Okay, so if your vagus nerve is not communicating with your SA node, SA node is not communicating with your AV node, you're not going to work properly. Okay, and once one of these fails, like your SA node starts to fail and it's done for, the next node will start to take over its responsibility. So now you're working at a deficit. Okay, and so on and so forth. All right. All right. So yeah, like I said, you'll learn about this in your EKG class. But basically, once it gets its signal from the SA node, the AV node will then send everything through the conduction pathways down the septum there and force those ventricle to get a message to contract. Each one of those little squares on the EKG thing is like it's like 0.1 second. So 10 of them is 1 second. So that's what we're trying to tell you here with that. So when I was a student here, they actually had to go buy EKG paper and trace it ourselves. I don't know what's going on now. I think y'all can just download it off the internet. And print it at home. But yeah, it's basically we had to draw our own EKGs and understand it that way. That way made me understand it really well. I don't know, nowadays y'all got these fancy things that do it for you. You can just tell what a co-pilot to, just generally say no, it does. Draw me a 0.1 strip. Boom, you're done. I did it, I swear. I did. All right, so it triggers the ventricles to contract, which is important. So we just learned what happens there. AV node, as I just mentioned there. So, yeah, so like I said, if one of them is damaged, the next one takes over. Okay, so just know the order: SA node. So your vagus nerve to SA node to AV node to the intervertebral septum to the Purkinje fibers, and we'll get to that in a second. But it also needs its own blood supply as well. So the right coronary artery supplies blood supply to the AV node. So bundle of His. So this one goes from the AV node to the bundle of His, which is found here at the intervertebral septum right here in the superior part right there. So that's another collection area there. So just understand the order of the electrical conducting system and where it is located, okay? And from there, we go down into bundle branches. Okay, we have right bundle branch and left bundle branch. You'll hear about left bundle branch blocks, right bundle branch blocks, and cause certain activity to appear in EKG. That's basically if anything's blocking, you're gonna have a dysrhythmicity between the two ventricles. Okay, and that's gonna create issues. Just imagine if your left ventricle is contracting off from your right ventricle. It's going to create flow issues and backup and all sorts of madness. So So that's why it's important for you to understand EKGs. And if you find someone comes with chest pain and they usually will come in from the paramedic. The paramedics usually use EKGs for you, and you can kind of read them. We always redid them in trauma. We're like, yeah, that's nice, thank you. You're wrong. Because right now we're taking over the patient, so it's on us. If court of law comes in, well, did you use your EKG machine? No, we use paramedics. You're done. Okay, all they got to do is create doubt, and you're done for. Okay, so always use your own stuff. I did that all the time. Oh, we've got X-rays from the. Oh yeah, nice, thank you. I get my own X-rays. And that way, it's in the system, in our system. So, but yeah, so your right bundle branch and left bundle branch are found in the ventricular septum, as you can see here. Let's follow it down. Then the impulse will travel to these Purkinje fibers, little tiny fibers that kind of spread out and innervate the entire ventricle to contract. Okay, so that's part of it there. So yeah, so I'm not going to ask you the 75 times per minute. That's more other stuff there. But just know the order, the sequence of excitation of these. Not going to get too technical for the anatomy class on the 0.1 seconds. I'll save that for EKG course in the fall. But just to understand that the impulses goes from the atria to the ventricles, basically through that pathway that we just mentioned. So all those little stops along the way that we just mentioned, I would like for you to know the sequence of that, the order of them. Don't get too technical as far as everything else. It's just anatomy class. You have to identify these structures, okay? All right. Sounds good? All right. So yeah. So it's basically what I just mentioned. So this is what it looks like. An EKG, you have your P waves, which basically represent your atria depolarized, contracting basically. So in your SA node starts to fire, see these P waves, okay? Sometimes P waves are absent, meaning that you have a diseased SA node. QRS complex is representing ventricular contraction, basically. So it'll change in width and height, and some will be missing sometimes, depending on how sick the person is. T waves, everything's just starting to repolarize and back to normal, and then it starts over again with a P wave, okay? So this is just to give you an idea of what each of the corresponding letters to each of the sequences of excitation is, but this is minutia. This is saved for your EKG class, okay? Or do you guys want to be tested on it now? No, yeah. Dr. Ovalle will teach your EKG class. She's excellent with that. So.
Sorry, so we don't have to like the waves now?
No.
Oh, okay.
No, that's for EKG class. I'm just kind of give you like an intro, like to kind of make it make sense in a way of why we're learning this. So the SA node, AV node, this is what it looks like on an EKG. Like each letter represents what, SA nodes are P wave, atrial contraction, QRS complex is your ventricles contracting. That we know what it looks like, but it's anatomy class. I'm not going to waste a question on that. But, okay, so yeah, just to review, this is matching the EKG complexes to the heart sounds. What do you guys think? You guys want to be tested on this? I like messing with you. Cardiac output. All right, so cardiac output is basically how much blood. All right, let's take a 5-minute break. You guys are losing me. 5-minute break. I gotta get some water. I'm dying. 5-minute break. We'll come back. All right, so same thing with anatomy. We like to classify everything. Okay, so in this situation, we have 5 general classes of vessels here. So these are basically very strong. They're going to be responsible for holding the high pressure blood flow, so to speak. They're kind of like the hoses the fire department uses versus the ones we have in our backyard, the little green ones that are cheap and break easily. So just compare it that way. So they're very strong. So they're the ones that are going to be shot out of your heart and go to the systemic circulation and feed all the organs. These culprits are your arteries, arterioles, capillaries, venules, and veins. So these guys are, as we get further away from the heart, what happens to the pressure? It goes down, yeah. So, and when the pressure goes down, we need other factors to help us get that blood back up. So that's where your calf muscles come in, the one-way valves to push the blood up to the right side of the heart, and other factors as well. So if someone is diseased, it's going to be a lot harder for that to happen. So I'm not going to ask you the layers of the arteries and veins. That's undergrad stuff, okay? Just know that there's a bunch of layers and muscles inside of them, and they push things along, okay? This was on last year's exam, but I got rid of it because it doesn't really pertain to clinical, right? Just if they're clogged with fat and arteries, that's what's important. What's a subendothelium? Go. Does that really matter? You tell everyone hey man, everything's okay, but your subendothelium, man, dude, doesn't work that way. Okay. All right. So aorta, big guy here. So he's very important. So he's an entire roadway. It's called the aorta. Okay. It literally shoots out like the Hulk ride and comes back down towards your thoracic abdominal region and spreads out into your lower leg artery. So the aortic arch, as we call it, we got the ascending aorta because it's ascending towards the top, right? So you'll have to know what areas it encompasses. So you got your three little guys there once again. Okay, so you got your aortic arch, which is the arch of your aortic ascending aorta because it's ascending out of the heart. It turns to an aortic arch, and you've got three vessels that come off of that. Okay, so you got your brachiocephalic, left common carotid, and left subclavian. Okay, so you have to be able to identify those, where they're located and where they're going. All right. So ascending aorta. This is just the aorta, basically by itself. Now you can actually do this exact thing in the anatomage as well. But we just get rid of everything except for this. And you can see, and what are these little guys right here? Semilunar. Yes. Of which structure? The aorta? Yeah, left ventricle. So aorta, yeah. So that's the start. It's basically the heart connects right there. So that's your semilunar valves. That's where it gets shot out like the Hulk ride. Your left ventricle is there, and then so that's part of your ascending aorta. And then you can see there those three branches that I need you to understand what they are. So left subclavian is the most left, and your left common carotid is right down the middle. Okay? And where does left common carotid artery go to? The feet or the head? Okay. Is it part of your circle of life? How do you know that? You just studied that a lot? Okay, cool. All right, so arch of the aorta. So if I ask you what three structures branch off the arch of the aorta, what are you going to say? And what happens, what do you mean by left subclavian? Does it go underneath the clavicle or over it? Okay, good. All right. And then your descending aorta is going to be classified as your thoracic aorta and then your abdominal aorta. We get something called a AAA, abdominal aortic aneurysm. And what happens with that is that intimal sheath right here of your aorta, if there's a tear inside the lumen of your aorta, like a little tiny tear, blood will continue to seep through there and it'll fill in the outer casing of that aorta and create like a huge bubble. And that'll create a lot of pressure, and that can eventually rupture and kill. It's called an aneurysm, right? So that is why in the next few weeks, hopefully, you'll learn about how to basically have to stick your hand right here inside of your partner's like transverse abdominis region and feel for the aorta pulsating, and then you can measure the width of that. And it's got to be within 5.5 centimeters for it to be safe. Anything greater than that, there's probably a little outpouching of blood collecting, and that's an aneurysm. Okay, so just to give you a little head start on what's happening there. Okay, all right. So this is what I kind of just asked you guys just now. So what happens as blood pressure gets away from the heart? Don't worry about that. And then as it tries to get up, our muscles, that's why when you're laying down, your blood has a chance of getting slowing down and stagnant and become viscous and create a clot. So we encourage people to walk. Your calves create veins are one-way valves. Right? So we all know that they can only contract up securely. So we need muscle contraction to help out as well as an assistive device. So some persons can get a bilateral lower extremity edema. They can get varicose veins, and all sorts of things that creates a pulling. The gravity is literally pulling fluid down into your calves and keeping it there. And these veins can only do so much, and we need muscle as well. But sometimes people can't ambulate or walk. So what else can we use for mechanical compression devices? We use compression socks. Excellent. And compression socks come in different varying millimeters of mercury depending on situation. So that will also, so now we're assisting with the one-way valves, we're assisting with muscle contraction and mechanical compression with these stockings, okay? All right, and then ambulation as always. And someone who's standing on their feet all day also, like a professor, or if you're going to be in the OR. When I worked in the OR, I wore Hokas. You remember those shoes? I those things saved my back. I extended my surgical career for about 5 more years. But yeah, I used to wear Hokas and like really high millimeter mercury compression socks because I started noticing I was getting some veins popping out my knee. I'm like, oh, I can't have that. So yeah. And also my feet were swollen at the end of the day. I had to elevate them. So yeah, if I'd recommend that even when you guys are in PD, well, you guys have shorts on. Don't worry about that. I guess you don't mind. You shouldn't care what people think anyway. But if you're on rotation next year, you're gonna be on your feet all day. I'd recommend you have them on. Okay. All right. The ones that go up to your knees. Okay. Not the short ones I have on today, but yeah. All right. So cardiac output is a formula: heart rate times stroke volume. So remember the little canoe example I gave yesterday? So the heart rate is the guy quickly trying to get the water out of the canoe before he sinks. Stroke volume is the amount of water he's able to put in his little bucket. Okay? So if he's got a high heart rate, like 200 beats per minute, how much water in that little bucket is gonna be minimal, right? That's what happens when people decompensate and pass. Their heart rate just goes through the roof and they're not pushing up blood through the system, circulation, so your organs die of deoxygenation. Okay? So heart rate. So if you've got a good strong contractile heart rate and it's at a good rate and you're have enough time to fill that little bucket of water and then dump it off to the side so your canoe doesn't sink. This is what that's optimal. Okay, heart rate times stroke volume is what we want. It's going to equal cardiac output. So if your heart rate is really, really high, really, really fast, are you going to be able to fill as much? No. So your cardiac output is going to be yes. But if you have a stable heart rate, let's say you're like a endurance runner, and you're trained to like be badass in that sport, you can keep your heart rate low, like in the 50s or 60s, and that's going to allow a lot of time for filling. So you're going to have a good heart rate and stable stroke volume to basically keep a good cardiac output. Does that make sense? So think of the guy in the canoe. He's frantically, crap, I'm going to sink. And then he's going to get so overworked and he's going to pass out and die and drown. But, if you got a stable, trained runner who's able to take deep breaths and control his breathing, controls accessory motion, because the more you move in running, if you do this, that's bad. If you run like this, you're being economical and you're kind of relaxing certain parts of your arms, you're basically conserving oxygenation to the muscles that really need it, your respiratory system and intercostals and focus, okay? So that's my 2 cents on stroke volume and cardiac output. Hopefully that helps you understand it better. Does it? Just think of a little guy in a canoe in the lake, okay? Oh my God, I'm sinking. That's high, fast heart rate, not enough stroke volume getting that little bucket, okay? All right, blood pressure. So y'all had your blood pressure taken before. So I was in my vestibular therapy 2 months ago, and the dogs were with me, and they took my blood pressure, and both of them like jumped on my lap because they thought something was wrong. Because they can sense when my blood pressure changes and my heart rate. They both jumped on my lap and like were pressing down to create that compression therapy, I guess. It was pretty cool, but therapist was like, "Oh my God, I'm sorry." Just relax, they're fine. They're just protecting me from your sphygmomanometer. But yeah, so pressure. So let me give you an example. So if I had this side of the classroom staying on that side of the door, okay, pushing against the door, and I had the two of you try to open it, what's happening there? What's that? That's lots of afterload, okay? So a lot of resistance. So that's basically what blood pressure is, basically. So remember your left ventricle is shooting onto your aorta, your systemic circulation. If there's a lot of resistance, like plaque and, your valves aren't working that well, stuff like that, that's how much pressure your heart has to push against to get blood out. So these two students here are going to have a hard time pushing against all 30 of you over there to open that door. That's high blood pressure. Okay, so let's do a 1-to-1 ratio. One person on the other side, one there. It's going to have an easier time opening that door and getting blood out. That's going to be, adequate blood pressure to allow everything to open. So when your heart is working against that side of the classroom to get blood out of the heart to systemic circulation, that's hypertension. And that can overwork the heart because these two students are going to be like, they're trying their all over might. They're going to get tired. They're going to get fatigued. And they're probably going to open the door a little bit to get a little bit of blood through there. And that's what happens with hypertension on the heart. It literally makes the heart so fatigued, overworked, and it leads to death too sometimes. But it's a silent. You don't have any symptoms with that. Your heart's basically a loner. Basically, it doesn't tell you when it's hurting. It doesn't complain at all. But it'll try its best to get that blood through there to everything else. So does that example make sense to you guys? Yeah. My anatomy teacher from way back at FSU. Yeah, that's the same exact thing he taught me, and I was like, oh, I'm going to use that when I'm a professor 40 years later. Anyways, but yeah, no, it stuck. It helped me, and that guy was like, he was a jack bodybuilder. He liked being in the middle of class eating a peanut butter jelly sandwich because his clock would go off because he had to eat at certain times. He'd be like, don't mind me, guys. I got a competition. I'm like, okay, dude. But yeah, that example right there literally stuck with me, and I am glad to share it with you guys. It means a lot to me to share it to you guys. Just side note there, okay? Hopefully it helps you guys stop. Been through enough for the last few years. So vasoconstriction and dilation. So constriction is basically when you're decreasing the diameter of the blood vessel, which can occur during muscle contraction and when you apply ice to an extremity. Okay, let's say your knee hurts, you put ice on it, you're causing vasoconstriction because that's going to push all that swelling out of the way into your lymphatic system. Vasodilation is the opposite. You're dilating, relaxing those vessels, and to create dilation, to open up that diameter. And when you apply a moist heat pack on your knee, that's what's happening. In vasodilation, and basically allowing blood flow to come in, more oxygenation, and everything's going to heal nice and easy, okay? So when you guys get hurt this next 27 months, you put ice on your knee, think of this, vasoconstriction. And you put a heat pack on, like later today when you're sore, you're sitting there all day, vasodilation when heat packs, okay? All right, so same thing as yesterday. As you age, your cardiovascular system slows down. You can't produce as much cardiac output as before. So walking becomes important as you get older. It'll at least give you something, add an incline to it that also pump it along. But yeah, so there's another model here you can use to study off of. But yeah, so I will. This lecture was recorded. Hopefully, I don't screw it up, and I'll post it later. Okay. All right.
Thank you.
Thank you, Professor. Take care.